It's my absolute pleasure to chair this half of the meeting, and we've got two excellent speakers. So I was just looking up on my iPhone what the definition of a polymath was, because I'm going to call Anton Harding a paediatric polymath, general paediatrician, paediatric endocrinologist, neonatal paediatrician. Ladies and gentlemen, there's nothing he can't do. And I'm sure, no pressure, Anton, but please join me in welcoming Anton Harding.
Good idea. Well, firstly, I'd like to thank the team for inviting me here today. It's obviously a pleasure to talk to you all. I'm going to talk about a bit of a passion of mine that's been generated over some time. And you can see that I've got Austin Health written there because that's one of the places I work, as well as the Children's and many other places, including Epworth, Richmond. So I'll need to use my glasses because I can't see properly without them. But basically, transition to adult care is a known high-risk period, and it can mimic the perfect storm, where it's very easy to be lost to follow-up, and there's increase of diabetes complications. And there is a change of healthcare professional, there's a change of environment, there's also a change of management style. And that can be quite a significant change for anyone who has gone from a paediatric care. There's psychosocial adjustments, there's financial stressors, which you've already talked about today. There's also moving out of home and also finding employment during this time. So there's lots of competing distractions. You can imagine that we've already talked about that. Phil's outlined, do I go to the pub or do I go to see my doctor in the clinic? Therefore, there's a high risk of disengagement. And of course, we want to talk about complications. There's a risk of short-term complications, which can be diabetic ketoacidosis, and also hyper and hypoglycemia. And then the long-term complications can be nephropathy, retinopathy, hypertension, cognitive decline. In fact, there were many on that list to talk about. So transition is a very important process. The young person is moving from parental-based care to individually-based care, and there are three phases that I've outlined here. So the first phase is, when we're talking about diabetes, is preparation. So what we're doing is we're moving from the paediatric-based care, so as an introduction, we usually try and introduce this process from the age of about 15 to 16 years, and then the actual transition itself comes from about 16 to 17 years. And for us in our group, we actually have a change of environment, so go from the paediatric clinic based at the main hospital to the YADS clinic based elsewhere. And for us, in our transition clinic, we have the same staff. So the same doctor is there, which is me. We have a diabetes educator, which will be the same person, and the same dietitian. And the third phase is the evaluation of how it is all going. So what are the differences between paediatric and adult care? Well, I've put here young children do not have the cognitive ability to master diabetes care, but you might say, who actually has the ability to master diabetes care on their own? It's a very hard thing to do. Even a young adult and even adult doesn't really have the ability to fully master diabetes care. You really need a team. And if you've got a team around you, it can make such a difference. So I think it's important that we just don't think it's about young children only. Now, in the paediatric service, and also when you're a child, there's family involvement, which Lisa has outlined terrifically how involved she is in the management of diabetes. So there's carbohydrate counting, and we could all ask you how many of you were good at counting carbs when you had your lunch today, which Lisa outlined. We should all be testing everyone, because no one actually stopped to actually do carb counting before they ate today. I noticed that, I was watching you all. So you've all failed, except for Lisa. Well done. So the other thing is insulin injection dose. So in other words, how do you decide what dose you're going to give? What should happen in reality in a paediatric situation is you sit down at the table, let's say it's breakfast time, you've done your carb counting, we know what our blood sugar is, what dose of insulin we're going to give. And so it should be a decision made by the team, if you like, which could be a parent and the individual. Some people just do it automatically without thinking. That can be fine if everything's very much the routine that you've always done. Doesn't always necessarily have a good outcome. Because as Lisa has outlined, your blood sugar could be anything that morning, where everything else was perfect the night before. So you do have to make adjustments on the day. And then, of course, you might be using an insulin pump. And insulin pumps are a different set of circumstances altogether. I think insulin pumps do have better outcomes in the longer term. Your HbA1cs are generally better. Your blood glucose control is generally better as well, because you're actually changing the management on the fly. In other words, you're making decisions as you go along. And that's how you can get better control. And your lifestyle changes as well. And so generally, you try and manage your paediatric control within the family lifestyle. As an adult, it becomes individual-focused care, and the individual makes their own choices regarding their care and actually who cares for them. If they don't want to see you, they'll go and see someone else. And if you have a way of being able to motivate them to come along and see you, then that can make a big difference. I'm going to talk about depression because it is something that was mentioned already in the previous presentations, but it is definitely a comorbid condition in diabetes, and it's linked to poor control and complications. And if you look at studies in late adolescents between the age of 18 and 20 years, it's said to have been 15 and 33% of those individuals with diabetes have depression. And emerging adults, it's slightly higher. And what's more is that the adolescent and post-adolescent young woman is 2.4 times has a risk of an eating disorder compared with age-matched controls without diabetes. And that is a real problem when we're looking after this age group. Other issues are 30% of all women taking insulin struggle with subclinical symptoms of disordered eating. So what they're really trying to do essentially is to omit insulin and become hyperglycemic, and that then causes ketosis and its ability to either lose weight or not gain weight. And that's up to 60% of individuals have that type of behaviour at some point in time. So mental health issues need to be discussed before, during and after transition, and therefore appropriate early referral is important. So I'm going to talk about the history of myself to some degree. So I started off as an endocrine fellow at the Children's, and we used to walk to the Royal Melbourne Hospital once a month to see our diabetes transition patients in an adult setting. And the aim was basically to see them once or twice, then hand them over to adult services. But it was a large waiting area, and when you looked at the waiting area, it was bigger than this room. There were lots of people in this room, and most of them are older adults. So if you're an 18-year-old and you've just come from the Children's Hospital where we've nurtured you all the way, and suddenly you're thrown into this big chasm, I thought, wow, this is really tough. And it was tough because we'd say hello and we'd say goodbye, and that was our only contact we had way back then. So I started off as a registrar at the at the Austin in 1986, and I was appointed as a consultant with 2 sessions in 89. And I had this passion, I wanted to set up a diabetes service. So I set up a paediatric diabetes service in 1994, and it was an adult hospital setting. And I needed to basically change the management of the team, particularly the educators, as to how we actually deal with paediatrics. So in other words, we had to have a different form of communication because we're dealing with children, we're dealing with adolescents, and also dealing with parents, rather than the individual-based care which you talked about before. We also had to have a change in fluid management in ketoacidosis. And also I wanted to have a frequency of follow-up post-diagnosis. I like to see the patients 2 weeks after diagnosis to make sure that things are on track before I would send them to our general follow-up clinic, which would generally be about a month later, and then 3 months after that. So it was a staged departure from hospital care. But I always wanted to make sure that we had contact so that the individuals, the families, could always ring the educator or the ward if there's any problems after diagnosis. So they always had some form of contact, so they could always be kept in touch. So the other part was that in order to have paediatric to adult transition, we basically would do this towards the end of school, and then we would transition to adult care. And what I used to do at the start was we used to get the adult endocrinologists to come to our paediatric clinic by invitation. They would come and meet the patients and the parents before they would go to their own clinic. And it didn't always work because the endocrinologists were busy, one visit may not have been enough, and the management styles were somewhat different. And so I wasn't particularly happy with doing it that way, but that's how it started. So I wanted to have a design in a transition clinic. How can we do this better? So I proposed an age range of 16 to 26, and I also proposed that the Austin we should have a secondary adult model, 26 to 40, rather than going to a huge big clinic, 26 plus. And that's still undergoing change at this point in time. And if there's any inpatient care required during this transition process, I wanted to be coming under our care rather than under the adult team, because the transition hadn't taken place properly at that stage. And I proposed that we'd have a clinic that would run from 4 till 7 or even 4 till 8 p.m. to try and fit in with the working lives of the attendees. It took 8 years to get this started, so it was a long time negotiating, because you imagine in hospital bureaucracy there's a lot of different things that have to go through different phases. And so what do we need in our clinic to get it to work? We need a space in a hospital somewhere, and we needed a team, because we want team-based care. We want to have a good way of communicating. So we needed 2 consultants, 1 paediatric and 1 adult. We wanted 2 paediatric registrars to come along, an endocrine adult registrar to come along. We wanted 2 nurse educators, a dietitian, an endocrine nurse, an HbA1c technician, and 2 clerical staff. So that's what we required to get this clinic to work. So where's the space going to be? So here's the hospital, the Austin. It's got 3 campuses. It's got nearly 1,000 beds, and we've got this is where the children's ward is, here on that floor there, in this building. That's the Mercy there. This is the new Olivia Newton-John Cancer Centre. And the hospital was first built in 1888 or something, so this is one of the old buildings still there, and the rest of this part was finished in 2005 when we built the new hospital. So we've got the 3 campuses. We've got the Austin Hospital, we've got the REPAT, and we've got the Royal Talbot Rehabilitation Centre. So which place were we going to pick out of all of that? Well, this is the only one left. So we went to pick up the REPAT. So where's the REPAT? So there it is, down the road. So you have to drive from the main campus down Banksia Street, and you get into the main entrance down here. You can get into the car parks, which are marked P, around the place here. And it's in that particular building there, called the Centre Building. Why is it called that? Well, there's the ship it's named after. It was actually built in Scotland in 1924. And there it is, it's the Australian Hospital Ship Centre. And unfortunately it was sunk off the Queensland coast. It's actually not so long, not far before the anniversary, but it wasn't actually found until about 1995 off the North Stradbroke Island, if anyone knows where that is, up in Queensland. So at the repatriation campus, this is where we had our clinic. So what happened was we eventually got it going. It was a monthly clinic. I couldn't run it at the time I wanted to, because staff have to go home, cost more if they stay any longer than 6 o'clock. So it was 3 p.m. to 6 p.m. And even then, the nurse that does the blood pressures, she leaves before that, because if she stays any longer, it's overtime, it costs more, so we can't do that. And before each clinic, we'd have a team meeting. And the idea is we would discuss each patient before seeing them. So we had a good idea of what was going on. So any new patient, there was a referral letter that would be coming from wherever it may be, and we would discuss any of the particular issues that that particular patient might have. So we all had a good idea of what was going on. And any of the review patients, they're often, they're very much encouraged to keep in contact with the nurse educators between clinic visits, and most patients are very good at doing that. So they'll ring in and say, we've got such and such a problem, and always in the notes there will be something there about what interventions were undertaken during that time. So where do our referrals come from? Well, most of them from within the hospital itself. Then we get a good percentage from the Children's Hospital, from GPs, and then from other places as well, as you can see. So during the waiting period, when they're sitting in the clinic, they can talk to each other. There's sandwiches and drinks, there's literature and pamphlets. And we used to have a large room next to where our clinic was, which had a billiard table in there. So they had great fun in there, but unfortunately it's been taken over by another clinical area, so we've lost that. But I'll have to negotiate another billiard table somewhere else. So what happens? They come into our, they check in. It's all electronic these days. They see the clinical nurse have the blood pressure and weights done. The educators will see them. We have two rooms for the educators. So there'll be a meter, pump downloads, there'll be management discussions, partly based on what we've already discussed before the clinic has actually started. Biochemistry technician will do the capillary HbA1cs on site. We have been running a research questionnaire. We did a trial for some time. I need to restart this again, by the way, and then they'll see the medical staff. So this is the area here. So this is where one of the educators' rooms is. Another one is around the corner over there. And then this is where the dietitian sits. And there's seats here. And then on this side here is where the rooms are, all the way down the corridor here and beside me where I'm taking the photograph from. So that's what it looks like. And then the next part is when they come in to see us in our room with the medical staff, the electronic scan medical record will have all the information there. So the meter and pump downloads are all visible there. The weight and blood pressures are visible as well. The notes that might have been written by the educator prior to seeing me will be all there on screen. And any of the past records I need to look at, any of the past tests that have been done are all there. So I've got a lot of information in front of me. We've partly made some decisions as to what we were going to do regarding management, and then we'll have a discussion as to what's required to change anything if necessary. I always try and give them one goal before they walk out the door. So I point to the door and say, before we walk out the door, what are the goal? What's the one goal we're going to make today? It might be changing some setting on your pump, or it may be doing some more tests, or it may be doing something completely unrelated to diabetes. But the idea is just to have something that's different each time. And then we'll endeavour to be seen every 3 months. So in this depression study we did, we wanted to identify who hadn't been surveyed. So in other words, we wanted to make sure we were surveying everyone who comes to our clinic. And we're using the Centre for Epidemiological Studies depression scale, which is very well known and used worldwide. And they'd fill out the questionnaire, and there'd be 20 questions there with a scale of 0 to 3. And it was all to do about how you felt in the past week. And if you had a score over 16, then that would alert me or the other doctor to say, well, maybe we need to have some intervention here, and we would refer those individuals to a psychologist as necessary. So when we did a pilot of this, when we first started this back in 2009 to 12, we found that 17% of our patients, which was 7 out of the 41 surveyed, that basically had depression, and they were referred on to ongoing services and have actually done very well. So what are the outcomes of our clinic? So we've had some very positive feedback. HbA1cs have been dropping since 2012 at 8.3, now to 7.9. Obviously you want to get to a goal, like all of us, under 7.5, which is the Australian standard now. And our fail to attend rate, when we first started, it was 2008 was our first year. 2009 was our first full year. We had a 38% fail to attend rate, but our reviews to news were obviously seeing more news than reviews at that point in time. Then in 2013, the actual rate dropped down to 17%, and the reviews to news were a little less, but we're seeing more of our older patients coming through. This year, we've got a 11.6% fail to attend rate. In fact, our last clinic this month, everyone turned up, not a single failure to attend. How about that? And our reviews are still, we're getting quite a few new ones coming through, so it's always good to see. So, technology. We've got to talk about technology. So, how many are using insulin pumps? The numbers are climbing. It's 25% that's going up and up and up, because we have a pump start clinic. Not everyone wants to be on a pump, but I think for the use of basically lifestyle, I encourage anyone to get onto a pump. Obviously you have to be motivated. Not everyone wants to have a pump. There's various reasons as to why you don't want a pump, because you get reminded you've got diabetes all the time because it's always with you, and that can be the negative. the positive is that your lifestyle changes quite dramatically. The problem with pumps is you've got to push the button. And how many people, particularly adolescents, push the button? Fortunately, the young adult group, they're more motivated, whereas the 13, 14, 15, 16, they tend to be the much harder group, particularly the 15-year-olds. I find that's the most difficult group when you're trying to get them to push the button on their pump. They just won't do it. So they tend to let their pump run automatic, whereas the older group are more motivated, and the more motivated they are, the better the control. And when they start to get HbA1cs that are better, but also they feel better, they can study better, there's the motivation to keep on going. And I think that makes a big, big difference. And the other thing is, now that you've heard about continuous glucose monitoring, being subsidised by the NDSS makes a big difference. Obviously, anyone under 10 years of age automatically can get subsidised, and then there's this certain criteria that are required between the age of 11 and 21. After 21, unfortunately, you don't get subsidised anymore. But we've got a starting clinic as well, which are 2 clinics a week, where we have 10 go on continuous glucose monitoring, 10 go off, so we can use that. And of course, more and more people who want to use it find they actually can see what's happening with their blood sugars, particularly overnight. Because the fear of nocturnal hypoglycemia is very high for anyone with diabetes, particularly parents, as Lisa will tell you. But I think it's extremely important to have that technology available, because it makes such a difference. So the areas of relevance when we're actually dealing in our clinic are obviously what I've mentioned before about the differences between paediatric and adult care. We're also talking about glycemic control and how you can actually better motivate individuals to improve their glycemic control. And partly it's to do with them feeling better, but also many other factors that keep them wanting to continue to improve how they look after themselves. The psychosocial issues I've touched on already, but then we also get into sexual and reproductive health issues, which come up quite often. I've even had individuals that are planning to get pregnant, so therefore we want to have good control. And here we are, I'm a paediatrician, I don't normally do this sort of stuff, but when you actually do what we do, you have to be a jack of all trades, and suddenly you're sort of being a counsellor, talking about sexual health, you're also talking about planning for pregnancy, you're also talking about getting good control, and suddenly you're sort of mastering all sorts of skills all at once. So David, you're kind of right, and you do have to sort of be a jack of many trades in this particular situation. Obviously there's the next part that comes up is alcohol and other substance abuse, but alcohol is a real issue. And I often will say to people on their way home, make sure you are eating before you actually go to bed. So the good old stop at McDonald's on the way home at midnight or 2 in the morning, so they don't go to bed and hypo many hours later, which will happen for sure. And the other thing I try and advise them is to make sure you're drinking water and alcohol, so you're not actually just drinking alcohol only. So there's lots of different issues you're sort of having to deal with simultaneously. And then there's the Drive Above 5 campaign, which has been advertised quite a lot. But what that really means is you're needing to make sure you're driving with your blood sugar above 5. And the only way you can really ensure that happens is that if you're starting to feel, well, firstly, before you drive, you need to do a blood sugar. And if you start to feel low, you should actually pull over to the side of the road, turn the engine off, and you're supposed to take the keys out of the ignition and throw them into the back seat. Might be okay in some roads, but not such a good idea on a freeway. Because the idea is you're supposed to make sure your hypoglycemia is under control before you actually restart the engine. The thing about that is if you get out of the car and you're still sort of a bit groggy, you're going to fall out in front of the traffic beside you. So I think that policy needs to be sort of looked at carefully. So you need to be careful who you're advising and how you're advising them. We talked about complications, and also we talked about loss to follow-up, but they're all very important factors that you want to actually look at overall. So I think finally, here I am, I've climbed to the top of the mountain with my son Tristan, who some of you know sitting on that table over there. He's a paediatric resident with us at the Austin at the moment. But we've just climbed up the top of Mount Warning. which is the first place where the sun hits the mainland of Australia. So we've just come up to watch the sunrise. So the idea really is that you can strive to get to the top. The way to do that is to really try and motivate individuals as much as you can for their diabetic management. And I've been doing this for a long time, and I think that the more you're able to motivate individuals, the better overall control you have. And it's just a matter of engagement, getting them just locked into how you can think for them to some degree, and ultimately can make such a big choice at the end. Thank you very much.